Hello, my name is Lukejohn Welch, and I'm an assistant professor of medicine at UCSF.
And my name is Justin Sewell. I'm also an assistant professor of medicine at UCSF.
Today, we're going to talk about our upcoming article that will appear in GIE called Practice Variation in Percutaneous Endoscopic Gastrostomy Tube Placement, Trends and Predictors Among Providers in the United States.
Enteral access procedures, typically in the form of percutaneous endoscopic gastrostomy, or PEG tubes, allows the short and long-term option of providing nutrients and medications into the GI tract for patients who cannot maintain adequate oral intake. Enteral access placement is performed among a variety of providers and specialties, yet there is scant literature on trends and factors related to enteral access placement in the United States. As a result, we wanted to examine the trends and the incidence of PEG procedures performed by gastroenterologists in the U.S.
As a result, we conducted a retrospective electronic medical review of upper endoscopic procedures that involved percutaneous endoscopic gastrostomy tube placement between 2000 and 2010. Data for the study were abstracted from endoscopy centers who participated in the Clinical Outcomes Research Initiative, or CORI. The incident rate and annual percentage change of PEG tube procedures performed in the U.S. from 2000 to 2010 was calculated. Additionally, multivariate logistic regression analysis was performed to determine predictors of PEG tube placement in the United States.
Over 800,000 upper endoscopies were examined in the study. The mean age of patients receiving a PEG tube was 62.7 years, with nearly half of all PEG tubes being placed in patients over the age of 70. PEG tube placement by any provider from 2000 to 2010 was 1.7%, with the majority of them being performed by gastroenterologists. Although the overall incidence of PEG tube placement by all providers from 2000 to 2010 remained constant, there was a statistically significant decrease in the incidence of PEG tube placement among gastroenterologists between 2000 and 2010. There were a number of predictors of PEG tube placement. Very young, very old, and non-white racial backgrounds were patient characteristics associated with greater PEG tube placement. In terms of practice setting, PEG tube placement occurred more frequently in a community or HMO environment and on the East Coast. With respect to provider characteristics, male providers were less likely than female providers to perform a PEG tube, and there was a trend that as providers were further out of medical school, they were less likely to perform a PEG tube procedure. Interestingly, surgeons and other providers, including non-pediatric and non-general practitioners, were more likely to perform PEG tubes than gastroenterologists.
Our study raises several interesting points on the topic of PEG tube placement. The first point is the apparent shift of PEG tube placement away from gastroenterologists to other specialty services. Reasons for this shift are many. First, other services, such as interventional radiology, have become more readily available and accessible. Scheduling is relatively easier. Placement of PEG tubes by IR only requires local anesthesia in many cases. And in most circumstances, a formal consultation is not required. Secondly, the increase in PEG tube placement by non-gastroenterologists, such as surgeons and IR, may also be a reflection of easier access to anesthesia and operating room services by these specialties. The second point to highlight from our study is the practice variation we noted in PEG tube placement. Given the invasiveness and risk of the procedure, debate and controversy surrounding its placement and high costs associated with enteral access placement, understanding its practice variation is essential. Yet, of the scant data that has been presented on healthcare variation with regards to GI delivery of care, most have focused on colonoscopy and upper endoscopy, with none examining enteral access placement. Evident in our study was tremendous practice variation based on a number of factors such as provider and patient characteristics, geographic region, and endoscopy setting. A number of reasons may explain many of these findings, such as provider communication, patient population, and healthcare settings, and in some cases, medical legal concerns. But importantly, all of these observed variations in our study have significant implications with respect to the quality, efficacy, and equity in healthcare service delivery for enteral access placement in the United States. However, more robust and well-designed studies are needed to further understand and address these important observations. In conclusion, this is the largest survey of PEG tube utilization in the United States. Significant practice variation was noted in PEG tube placement with respect to patient and provider characteristics and endoscopy settings. Now that we have characterized the demographics of patients receiving PEG tubes, we need research to determine if they really benefit in terms of nutrition, survival, and quality of life.